Rise. No? Go this way. Please. Please be seated.
I open this academic ceremony in which Rekiku Fikre Abebe will defend the academic thesis, the effect of midwifery-led continuum of care to improve maternal and newborn outcomes in Ethiopia. May I invite you to present a summary of your study and the conclusions of your thesis.
Okay, thank you, highly estimated prorectors, dear opponents, dear my supervisor teams, colleagues and families who are watching online. In the next 15 minutes, I will try to summarize my PhD thesis, so hopefully you will enjoy it. Yeah, so as you can see from here, the topic is the effect of midwifery-led continuum of care to improve maternal and newborn outcomes in Ethiopia. So before proceeding to the main content, let me say a few things about my country, Ethiopia. So Ethiopia is found in the horns of Africa and one of the oldest independent country in the world. It's the second most populous country on the continent with a total populations of 126.5 million peoples, which is the second largest next to Nigeria. And the other thing you need more about Ethiopia is it is the land of coffee. It is the first leading country who export coffee to the globals and the fifth in the world. And specifically when you come to the study districts, as Ethiopian we do have so many cultures, and today I would like to share you one of the culture which is mostly practiced in our study area, which is Fiche Chambalala. It's a traditional New Year festival celebrated in Sidama district, which is registered under the UNESCO. So when you come to the points of the health system in Ethiopia, so the first health system policy was established in Ethiopia in 1993. Before 1993, there is some practice of the healthcare system, which is in the fragmented way. There is no policies, and most of the practice are based on the curative approach, and it is more prone for in the rural area, and the urban area are more neglected. The rural area are more neglected. So after 1993, the first health policies, the system have been organized into three-tier models. In the primary level, secondary levels, and tertiary levels, as you can see from the graphs. In the primary level health cares, the health postes, the health centers, and the primary hospitals are encompassed. And in the health postes, the health extension workers play a leading role in managing things in the health postes. And currently our governments also adjusted the structure of health postes into two, the basic health postes and the comprehensive health postes, so that in the comprehensive health postes, addition with the health extension worker, the midwives and the nurses are going to work in the health post levels. So in the secondary level, we found the general hospital, so that it is a point of entry for those cases who are not managed in the primary level, refer to these general hospitals, and those cases who are not managed in the general hospital will be referred to the tertiary level or the most specialized hospital. So the government of Ethiopia have been implemented so many plans, and one of the plan implemented in our country is the health sector development plan in different phases. And one of the main ultimate goal of this health development plan was the expansions of the infrastructures, the expansion of the service deliveries, and the recruitments of more professional at the service delivery points. However, having so many implementation, still in Ethiopia there is a limited access to the quality of the services. As you know, the issue of the maternal and newborn care is significant global health burdens. In 2023, 216,000 maternal deaths have occurred, but when you compare this figure with the last 2 decades, there is a significant reductions, which is around 41%. Having said this, each day 800 women are going to die in the world, and from those 90% of these maternal and newborn deaths are happening in the low and middle income countries. So Ethiopia is among these low income countries having such kinds of significant public health manifestations. In Ethiopia, it is clearly shown that there was significant decline in the maternal deaths. From when you took the figures in 2000, there have been 871 maternal deaths per 100,000, but the recent data from the Ministry of Health of Ethiopia in 2025 indicated that the maternal mortality have been declined to 195 and the newborn mortality have been declined to 29 per 100,000. It clearly showed that there is a significant improvement. However, when you compare this decrement with the targets which is tested by the Sustainable Development Goal by 2013, it's clearly showed that the more works have been needed in order to achieve the targets. For example, in terms of the maternal mortality, they expected to achieve is 17 and the newborn is 12. So if you compare this number with our achievements, still a lot of works are expected. To say a few things in the local context or the study, the place where our study was conducted, in Sidama districts, the maternal and newborn the problems have been prominent here. Due to lack of access to the skilled birth attendants is one of the things we manifest in our study districts. Again, there is a poor access for person-centered care. And I can say that there is a lack of continuum of care. The care have been given in fragmented ways, and the socio-economic disparity is one of the challenges in the Sidama district. This factor will lead to poor maternal and newborn outcomes, and majority of the women have dying with obstetric hemorrhage, infections, and hypertensive disorder, which is easily managed by providers, but due to shortage of those factors, many of the women are suffering with this. So as indication, as you can see from the slide, in the Sidama region, it's one of the highest maternal mortality rate, which is 419 per 100,000 live births are dying in this district. These figures are, it's an average, but it varies from district to district. In some of the districts of this Sidama region, the maternal mortality was reached to more than thousands. So after assessing these conditions with my team, we are decided to implement this midwifery-led continuum of care as an interventions. So what are the basic things that this midwifery-led continuum of care as intervention will answer our problem in the districts? This midwifery-led continuum of care is led by a midwife, so that the midwife is responsible for planning, organizing, and delivering the service from from preconception to the postnatal care, so that it is led by the midwife. And the principle of this midwifery-led continuum of care is that the care is given by a team of midwife from antenatal to the postnatal care, so that the midwife has a close relationship with the mother, that increased trust between the women and the midwife that can have its own impact. And the other important point in this intervention is that the women are engaged in the decision-making process of the care they receive from the midwife. That is also the important point. Again, this midwifery-led continuum of care is governed by its own principle of model of care, and one of the basic principle is equitable, so that in the midwifery-led continuum of care, the women are getting the service irrespective of their socio-demographic differences, so that this is the other unique feature of our intervention. Again, this midwifery-led continuum of care have been given in an integrated way, so that the other provisions are also closely work with this model of care in case of managing complications and in case of referrals. So during our intervention implementations, the first thing we have done is that discussion with the stakeholders, since this model of care is new in our healthcare system. So we need to discuss this point with our stakeholders, including the regional health bureau, the hospital manager, the midwives. Then after having a consensus on that, we give a capacity building training for midwives and seniors. The training is more of on the principles of the midwifery-led continuum of care. After giving the midwife a training, then we give orientation for the health extension worker. This is one of the important things we implement during our study, since we are conducting a prospective follow-up study. One of the things we fear is there is high number of loss of follow-up. So in order to adjust that loss of follow-ups, we integrate our model of intervention with the health extension worker in order to minimize the loss of follow-up. So supervision was conducted to implement the intervention, and finally the intervention was evaluated to measure the maternal outcome, the neonatal outcomes, and the maternal satisfaction. So during our studies, we implement different methodology so that the study was conducted in the governmental 4 general hospitals. And as a design, we use unmatched case control studies, systematic review and meta-analysis, and randomized control trial have been used as a design. And our targets are low-risk pregnant women, are newborns are our targets. And we measure at the end the maternal outcome, neonatal and maternal satisfaction. So our objective have been concluded with 4 studies. We classified these 4 studies in phase 1 and in phase 2. In phase 1, we conduct study 1 and study 2. This gives us to explore the factors and to test this model of care have been implemented in low-income countries, since this midwifery-led continuum of care have been much more evidence in the high-income country. After having this evidence, we progress to the phase 2, which is implementations of this midwifery-led care to measure its effect on the maternal newborn outcome and to assess the experience of the woman towards their stay in the interventions. So study 1, it correlates of adverse outcomes of adolescent pregnancy in Sidama region, Ethiopia. So during this study, we use as a method structure interview in addition with the medical record review to verify the diagnosis. So that in this study, the main finding is that the socio-demographic plus the healthcare system are the factor which can prone adolescent for adverse outcome, including a monthly income below the poverty level, lack of antenatal cares, women experience gender-based violence, and refer with obstetric complications have higher risk of adverse outcome where compared with the other. In study 2, we conduct meta-analysis and systematic review and meta-analysis in order to generate evidences. So multiple electronic database were searched, studies were screened, and finally we conduct an analysis. In this study, we found a result that women in the midwifery-led continuum of care has been significantly reduced the risk of emergency cesarean section by 51%, increased also vaginal birth by 14%, reduced the rate of episiotomy by 54%, and admission time were also decreased by 41%. At this moment, we decide that this intervention has many impact apart from improving the maternal and newborn outcome. So study 3, it is a part of the implementations of our interventions, which is the effect to test the effectiveness of this model on the maternal outcome. So it's a randomized control trial have been implemented in the 4 hospitals, and 470 low-risk pregnant women were recruited, and we followed the women. So as a result, women in the midwifery-led continuum of care have been higher also vaginal birth, lower chance of preterm, and low risk of cesarean section, as well as low risk of episiotomy. So the last paper, the last study is exploring the women's satisfaction during the interventions. We conduct an exit interview were done, and the findings stated that women showed strong preference of seeing the same midwife during antenatal, intrapartum, and postnatal care. As evidence here is that women are more interested while they are engaged in the decision-making processes. When you compare the satisfaction level in terms of the service provided, as you can see from the graphs, those women in the midwifery-led care have higher satisfaction in the delivery and postnatal care when you compare with women in the shared care. So when you conclude our findings, so midwifery-led continuum of care improves maternal and newborn outcomes in low-resource setting like Ethiopia. That is one of the things we explored. And women receiving midwifery-led continuum of care reports higher satisfactions during their antepartum, intrapartum, and postpartum cares. And the other thing we conclude is that midwifery-led care empowers midwives with great professional autonomies, allowing them to provide continuous high-quality care throughout their maternity period. When it comes to the implications of our study findings, currently world leader organizations are producing a paper to for low-income country to adopt this midwifery-led continuum of care strategy to lower their maternal and newborn mortality, so that our study have been an evidence for those countries to adopt this model. The other one is it is an evidence for scale-up, since our study proved that this midwifery-led care have been improved maternal and newborn outcome. It's a potential for the health systems, strengthening in quality improvement. When midwives are involving in continuous care, they have been sharing experience with their seniors, so that the quality of care have been increased. It enhanced satisfaction in women-centered care due to the interaction between the women and the midwives. Will improve this one. And the other thing is that the policymaker should consider this midwifery-led continuum of care as a viable strategy in order to combat this high public burden. I thank you. I think I will back the stage for Rector.
Thank you for your presentation. The opposition will be opened by Professor Krone, Professor of Prevention and Community Care at this university. Professor Krone was also the chair of the assessment committee.
Thank you. Dear candidates, I would like to begin by complimenting you with this work. And also complimenting your supervisors, because it's an important work and you have shown to have been able to improve maternal health care. But I will start with a short question. I think it's an easy question. In your opinion, which aspect of actually this midwifery-led continuum of care was now the most important for the observed outcomes that you had? So what is, according to you, the most important? Is that the continuum of care? Is that the type of care, the personalized care that is provided? Or is it maybe that they attended more?
Okay, thank you, highly esteemed opponents, for your questions. Yeah, it's a good question. So when you say our interventions, the most important aspect we observed during our study is that most women are feeling well and confidence while they have a good communication with the midwives, and the most especially when they engage in the decision-making processes. In our country, most of the challenges are coming from that most of the medical care decisions are made alone by the healthcare providers, and the women are not involved in the decision cares. That leads the women to utilize the health service in low coverages. So in that perspective, I think these aspects will increase the service utilization as well as the maternal satisfactions of care. The other problem in our country, in Ethiopia, is that there is no communication at all between the care providers and the women who are receiving these maternity services. So these communications help for the women, especially in a country like Ethiopia, when the people are coming for seeking health care. They are not only want to share about their medical cares, but they want to share the other aspects of their social and economic aspects.
And they do that?
Yeah, sure, yeah. So due to that, when they get a provider who is having a compassionate and a good communication skills, they are happy to share so many things apart from their medical practices. So the three important things we figure out: the communication, it's an individualized care, and the decision-making process is the most important thing we figure out during our implementation.
And then the attendance you don't feel, because they also attend more, but that's also an outcome then, because of this care, they also attend more.
Yeah, sure.
So it's not only if you do it in the normal care that you increase attendance, that they will have the same outcomes.
Yeah.
Okay. But then this communication, I'm interested in that part, because in your chapter 2, you also mentioned it, the gender-based violence. You see that there's a correlation between gender-based violence during pregnancy and adolescent pregnancy and outcomes. And yeah, I was also struck by the prevalence. I also know from research in South Africa that it's quite high. So that's my question: what can we do about this, and how? Because you mentioned in your discussion that you have to change how you look at pregnancy and all this kind of thing. But what is the role of midwife in this, and how?
Thank you. Thank you once again for your questions. Yeah, gender-based violence is one of the factors which prone adolescents for the adverse outcome, which is proved by our study. Actually, this gender-based violence is not only for the adolescent, but it is for the general population. So, what will be the role of the midwives in order to combat these gender-based violences? Let us see in different perspective. So, when the women are coming in the involving in the care process, in the midwifery care processes, as I said before, they do have clear communication with the midwife, so that the midwives will deal, apart from the medical aspects, the other social issue. The other thing is that in our country,
so then they discuss there, and are they also able to discuss this gender violence?
I'm coming to that point. Okay. Yeah. Apart from that, women are not the one who decided to seek care at the facility levels. So that this midwifery care is work integrated with the community health workers. So one of the impact of this midwifery-led continuum of care is creating an awareness about health and health-related problem by integrating with the community health workers.
They also can discuss it with the community health
workers.
Sure.
Yeah, sure. So during that session, one of the topic might be the influence of gender-based violence against the adverse outcome of maternal labor. So during that session, the partners, the family members also engage in these discussions, and they might create an awareness toward this, how this can be affect their maternal and newborn outcome. That is one of the things we entertain during our implementation, and we see some points. Let me give you one scenario we observed during our implementations. In the one of the health facilities, one of the women who followed during our study have been absent for like 3 or 4 days regarding with her appointment time. So we communicate with the health extension workers, and the health extension workers told us she has a fight with her husband. So we asked why, and her husband is refused for for a wife to go and have an access in the facility. So during that time, we create a communication with the health extension workers by engaging not only the health extension workers, engaging those religious persons in the community, so that we move to the house of those householders.
And then so the midwife is going to the house? So is that,
sure.
So that's really...
The midwife, in collaboration with the community health workers, move to the house of that individuals and ask them why he refused to send her wife to the health facility. And at the end, we explore that it is a clear knowledge gap is there, because most of the mother in...
And he accepted that?
Yeah, I'm coming, sorry. And one of the things we figure out at the discussion time is that he believed that most of the women in Ethiopia in the rural parts are giving birth at the home. So what are the additional benefits she got going to the health facility, since our neighbors are giving birth at the home? So that the midwives and the health extension workers explain the effects of giving birth at the home. Then finally he agrees and sent back to the facility. So integrating midwife, integrating with the community worker, involving the highly respected individual in the community, which help us to combat gender and other issues.
I think my time is over, but I think it's interesting. It's also something to think about in the Netherlands, because but then I'll discuss that later with you. Yeah.
Thank you. Your position will be continued by Professor De Weert, Professor of Psychobiology of Early Development at the Radboud University, Nijmegen. Professor De Weert was also member of the assessment committee, and we highly appreciate your participation in this academic ceremony.
Thank you. Dear candidate, I would like to first congratulate you and your promoter and co-promoters for the well-rounded, solid PhD thesis that you presented. I could see that you did a huge amount of work and probably challenging conditions to gather all the data, so I thought that was admirable, and I enjoyed reading it a lot. I learned a lot as well. But I want to ask you 3 questions, short questions with short answers, because I want to ask all my questions, so that's why I'm ambitious. So first of all, can you tell me, midwives and gynecologists, what's the sex ratio, the gender ratio Are they men? Are they women? You're a man, and I think that's really
Yeah.
great, but what is normal in Ethiopia?
Thank you, highly esteemed opponents, for your questions. The ratio of the midwives in Ethiopia are almost 50-50. Yeah.
Okay.
In
In
undergraduate
gynecologists?
levels, most it's 50-50. In diploma levels, all are females. When you come to, in terms of the educational levels, there are a diploma midwives, so all are females. When you come to degree levels, it's almost 50-50s. When you see the compositions of the gynecologists, I don't know the exact figures, but there is a mix-up of male and female.
Also more or less half-half. So it's,
Inside of gynecologists, I say that males are more dominant than female.
okay. Because did you look at, you had midwives that volunteered for your study, were they mostly female or were they also representative 50-50?
It's 50-50.
Did you look at sex differences in satisfaction and of the women?
No. No.
Should do that.
Yeah.
I think, well, you said that they talked a lot. I can imagine that maybe they feel more comfortable talking to a woman, maybe not, I don't know. I don't know how their religion plays a role, maybe in talking about partner violence with a man or with a woman.
Yeah, but in our context, the women are preferring based on the type of care they received. Since I'm a midwife, I was working in the clinical area for 3 years, and from that time, what I observed is that the preference of the mother is based on the type of care they received, irrespective of the sex of the health profession. So that is why, as I think, we are not thinking the sex ratio in terms of the maternal satisfaction.
Okay, but you could check it. And one other question. You decided to do the intervention in different hospitals, right? And you saw that the two groups were quite different in demographics. There were very large differences. So I wondered whether the effects that you observed cannot be because of these differences. I'm talking about chapter 4 now, where you found much, like the control group was much more rural, and could this explain some of your large differences in outcomes?
Yeah, thank you once again. I think this is good questions. Yeah, we select 4 general hospitals, and which is quite different in terms of geographical areas, in order to avoid contaminations and interventions in the controls. But during our selection, the one we critically think is that those 4 hospitals have serving the same service with the same standards, and also they are found more or less in similar kinds of habitat. For example, if you took one of our intervention sites is Yirgalem General Hospital, it's a kind of general hospital which is found, which is few apart from the urban area. If you consider again the Bona Hospital, which is the same, which is far from the urban. So it's more or less all of the hospitals are relatively, it's not quite different.
I'm going to interrupt you, but the demographics were quite different.
Sure.
So it's against what you're saying now. You're saying the hospitals are comparable, but they were completely different populations. So it could be that some of the results are due to the different populations. Is that true?
I don't think so. I don't think so.
Yeah.
I don't think so, because
you believe in your study,
yeah.
Okay. Could you have done to avoid this problem? Could you perhaps have looked at your care as usual before starting the intervention in the same hospitals? Would that have solved your problem?
Sure. Yeah. I think one of the things I observe at the end of my study might be it's better to consider a baseline data collection and considering different analytical methods in order to control those confounders. I will accept that comment, sure. Yeah.
Okay. Do I have? Yeah. Okay. And then I was wondering, I think you have really great numbers, and it would really improve to install or to instate in Ethiopia midwife-led continuum of care. Here in the Netherlands, midwives, when something goes wrong, get kind of a backlash from obstetricians, from the government, from people in general, the public in general. Are you afraid that that could occur and that they would, get a bad name, or because obstetricians are seen as the more highly qualified? Do you see any dangers there from upscaling your interventions and your?
Okay, thank you once again. Let me answer this question in two different dimensions. From the study we conducted, the teams are from team of midwives with one senior obstetrician. So at the first instant, we give training for midwife as well as those senior obstetrician for each hospital, because those low-risk pregnant women might develop a risk, so that the midwife easily communicate with the seniors in order to manage that complications. In our study context, there is no an issue. But during the phase of the scale-up, I'm working with the Ministry of Ethiopia, developing a policy regarding this midwifery-led continuum of care, and we are facing a challenge from, one of the challenges we face from is that from the obstetric and gynecologic associations, they are not at this moment, they are not comfortable, not willing, they are not comfortable with this model of care, since until this moment, the practice of midwifery has not much recognized, apart from saying that they are contributing to improve maternal and newborn outcomes. And even though there is no evidence to declare that midwives have contributed in order to decrease maternal newborn care in these numbers, because there is no such a researches. Due to that perspective, the gynecologists have some concerns, but we have already conducted 2 meetings. I think they are reshuffling their idea and might be, they are okay with this model.
Give them your thesis.
Thank you.
Thank you.
Thank you. The opposition will be continued by Dr. Tegene, Assistant Professor and Postgraduate Coordinator at Hawassa University in Ethiopia. Dr. Tegene was also member of the Assessment Committee. Dr. Tegene, you can ask your questions.
Thank you, dear Prorector. Dear Rekiku, I would like to express my sincere congratulations on your remarkable achievement in completing this significant and impactful thesis. Additionally, I wish to express my admiration for your publication record. So far, you have published 2 of your papers in high-quality journal, reputable journal, and the remaining 2 are also under review, with the expectation that they will be published soon. This is one of an indicator of the quality of your work. Using this opportunity, I would like to convey my congratulatory message also to your promoter, families, friends, and all staff members of Hawassa University, College of Medicine and Health Science. Saying this, I would like to ask you a few questions based on your thesis. My first question is somewhat general. In your thesis, you noted the fragmentation of service, where traditional care involves multiple providers, leading to disjoint experience and the gaps in care. I completely agree with your assessment. Fragmentation can impact the service quality. But however, when we see our context, most of the services that are given in Ethiopia are given at primary healthcare unit level. You have already described it very well in your introductory part of your thesis. The lowest level of primary healthcare unit in Ethiopia is health post. These days, actually, health posts are already categorized in different categories. My focus is on the optimized one, or the basic health post. As you know, in the basic health posts, the staff members that are deployed are health extension workers, and a few clinical nurses, like 1 or 2 clinical nurses. So given this context, how effective do you believe the midwifery-led continuum of care can be improving the current situation? That's my first question.
Thank you, esteemed opponents. Thank you for your congratulations and your questions. So, in principle, this midwifery-led continuum of care have been implemented in different stages, starting from the community to the more highly specialized hospitals. But when you come to our context in Ethiopia, yes, you are right that in health post, the new initiative classified health post as the basic health post and the comprehensive health post. So we are dealing with the comprehensive health posts. In the comprehensive health posts, there is a health extension worker with midwives and nurses. I agree that the number of the staff at that health post will be very minimal. So what was the intentions of our study? The intentions of our study is proving that there will be an alternative strategy in order to reduce these highly public figures, so that we are already proved that evidences. So when you come to the implementations might goes in different stages. So at this stage, we prove that this intervention might be effective at the hospital levels. So when you think to implement this intervention to the health center, to the health posts, first things must be arranged, including the recruitments of more midwives at the health centers and the health posts will be one of the things should be considered. The other one is organizational restructure might be the thing we consider, because most of the midwives in our context are not in the leadership position, so that might also affect the situations, and also needs an awareness creation might be done more in order to implement this model of care at the lower level. So at this level, I agree with your concerns, but I believe that the ministry will work on recruiting more midwives, because basically there is a standards on the number of midwives, nurses and other professionals who have been assigned in each facility, so that this will be a golden opportunity even for the healthcare provider to get a job position. So at that point, that might be implemented and become more practical.
Okay. Chapter 4 or paper 4. In your paper 4, you compare the maternal satisfaction between the new model and the routine one, the traditional one, finding that significant proportion of mothers express satisfaction with continuum of care require more effort, or does it have an extra package than the traditional one?
Thank you once again. Yeah, when you look the satisfaction levels of the women who have been engaged in the interventions and in the shared group, there is a significant difference that women in the intervention groups are more satisfied when you compare with in the shared cares. This is due to the fact that in the midwifery-led care, the midwives are implementing their activity based on the principles of what the midwifery-led continuum of care have been stated. Specifically, I have mentioned previously the three important components. One, the interaction between the women and the midwife is the pillar. The other one is the decision-making engagements of the woman in the care processes. The other one is this approach is based on the individual needs, based on the need of each and every woman. So that on this perspective, yes, the women are more satisfied on their experience during the satisfactions. So had it been this a new thing when you compare to the shared components? Yes, because in the beginning I said that in our country, in the healthcare system, the implementations of the maternal healthcare system have been fragmented, so that the care is provided by mixed up of professionals, so that the woman may encounter me in the first contact and she might face other provider in the next, so that might be the cause for dissatisfactions on the maternity care services. So that might be a great opportunity for our ministry to, because it is easily aligned on the existing system to attach this model of care in order to increase the maternal care satisfaction on the maternity period.
Yeah, I have a follow-up question, Rekiku, here. In your thesis,
now the opposition will be continued by Professor Nieuwenhuizen, Professor Midwifery at this university. Professor Nieuwenhuizen was member of the assessment committee, and she is also the secretary of this degree committee.
Thank you. Dear candidates, first, of course, also my compliments. It's a beautiful thesis and very relevant, not only for the mothers and babies in Ethiopia, but also to show the position of midwives and the valuable work they do around the world. And I'm really happy to read it, and it was interesting to read. And I'd really like to ask some questions. First, a remark. I think in the Netherlands it's 50 male midwives on 4,000 midwives. So that's quite a difference from Ethiopia. I want to talk about chapter 5, the satisfaction, and I really to understand how you measured the satisfaction. You mentioned that it was a 24-item instrument, but it's not clear to me how it was developed. You mentioned in your discussion that it was based on validated instruments, but I didn't really have an overview. So could you tell me a little bit about the background of the instrument, how it was developed, and what validated instruments you used to develop it?
Okay. Thank you, highly esteemed opponents, for your questions. Yeah, I think there is a huge discrepancy on the number of proportions of midwives here in Ethiopia, so thank you for that information. When you come to your questions, we assess the maternal satisfaction by using 20 questions, by classifying these 20 questions in the antenatal, intrapartum, and postnatal sections, and the questionnaires were adopted from similar study, which is a validated study which have been conducted on the northern parts of Ethiopia, which is already published, which is found in the Women in Childbirth journal. So I accessed that validated questionnaire from that journal. So the strata of the question is a kind of the Likert scale. So the woman during the postnatal exit, they will ask it like, do you feel that, are you comfortable seeing the midwife at Tennessee to conduct you at the labor time? Are you okay with that? And they said yes or no. The same question is gone. Are you willing to be happy to be seen by the midwife who have been engaged in the labor to the postnatal? So the kind of the question type is like that. It is in terms of the Likert scale. Then finally we calculate the mean weight as the end to declare that the mother were satisfied in their care process.
Well, it's an interesting questionnaire because it gives quite a lot of detail about both the different phases of the care, the antenatal care and the postnatal care and the natal care, but also going deeper into how the interaction with midwives was. Yeah. And in that it's more measuring experience rather than just satisfaction. And so it's very helpful also when you start implementing to know these details. What I understand is it was filled out postpartum in face-to-face interviews. So how long after birth were the questionnaires filled out?
Okay, thank you once again. So in order to assess the maternal satisfaction, we use an exit interview. So in our structure in the healthcare systems of Ethiopia, after the woman should stay at least 24 hours after giving a birth. So sometimes the woman will urge to move to the homes, and sometimes they will wait until the first 24 hours, since the first 24 hours is the most critical period for the mother and the newborn, so they should be assessed in the hospital. So the exit interview have been conducted after birth within the first 24 hours.
And so did you have any concerns about recall bias, especially about the antenatal care and also the socially desirable answers, because it was a face-to-face interview?
Yeah, actually, in order to minimize that biases, we use an independent data collector apart from the midwife, so that the mother will come conduct an interview with an independent provider from other side, so that I don't think so there is a high social desirability bias. Since the midwives are going to ask them, sure there will be a desirable bias, but there is an independent data collector who conduct that an exit interview.
Okay. I also like to look at table 2 in chapter 5, and it's, I think I put that, no I didn't. It's on page, on page 117. And you talk about gravidity, distinguishing between primigravida and multigravida. And I'm wondering if a woman had a miscarriage at 12 weeks and she was pregnant again, in which group was she included?
Okay, in terms of this category or?
Yeah, just to see where women, because usually we talk about parity and saying, well, women were nulliparous. So would the primigravity group be a nulliparous group, or would women who had a miscarriage or something be excluded from this, and all just first-time pregnant women?
Yeah, in this context we exclude the abortion miscarriage, which is before 28 weeks of gestation. In our context, the standard definitions of the miscarriage or abortion is the woman who is going to be miscarriage before 28 weeks of gestation is so-called abortion, so we incorporate that on that gestation age.
Yeah, but you would exclude her from the
study, sure.
Study, but
Yeah.
if she had one in the past and was now pregnant with an ongoing pregnancy,
Yeah.
would she be included
No,
in this?
no.
Still not.
Yeah.
If she had a stillbirth or a...
No.
Yeah, she would be excluded. Okay, that explains a little bit. Then I'd like to go to figure where you... let me see, figure 3 on page 127, where you look at women's evaluations of antenatal and interpartum care with different categories. And one of the categories was perceived quality of care, information combined with the information provision and the relationship with midwife. And then there was the category overall satisfaction. And I'm wondering, why did you combine the provision of information and the relationship with the midwife in one category? Because I think it would be valuable to know the two separate ones also if you start thinking about implementation.
Yeah, thank you for your questions. Okay, thank you for your questions, and I will consider it as a compliment since you are already done in combined way. Yeah, it's a valid comment.
Okay, thank you.
Thank you. The opposition will be continued by Dr. Hoving, Assistant Professor Health Communication at this university.
Thank you. Dear candidate, of course, I would also like to congratulate you with all the work that you've done, and you've written it down very accessibly and really helped me to get into your story and follow along. So compliments to you, and of course also to your supervisory team. The question I have relates to something that is not in your dissertation, and something I think perhaps would have added benefit to it. When I look at your chapters, I see a lot of quantitative work, so a lot of questionnaires, data then derived in numbers, and that is then analyzed in a statistical manner. But I don't see a lot of qualitative work. This is something that's very interesting to me, and I'm wondering whether this is something that you are also missing, or perhaps it was a deliberate decision to do that.
Thank you, esteemed opponent, for your questions. I think it's better to consider the mixed types of design while conducting your study, but it all depends on the objective you want to measure at the end. So for our objective, for our study, it's enough for us to use the quantitative parts, but yeah, maybe at this stage, if I got an opportunity, I will accept your comment, especially exploring the perceptions of the midwife, exploring the perceptions of the stakeholders, since it is very important for the implementation processes. But at that moment of our study, I think the method we use is enough to answer our objective.
Okay, I understand that you have to make choices. So, looking back to your project, if you could do it all over again, if by some magical happenstance you would end up at the start of your project again, would you incorporate it then, and if so, where?
Good. sorry if I got your questions. Engaging the qualitative design. Thank you so much. Yeah, if I got an opportunity to do my project back again, is maybe I will consider two things apart from the qualitative aspects. I will add the qualitative aspects in chapter 4, as I said before, to explore the perceptions of the midwife, since the midwives are the role actors for implementing these midwifery-led cares. So we need to figure out their perceptions about these cares. Again, the stakeholders, the one who are implementing the models, including the regional health bureaus, the hospital manager, in terms of the resources, the time, the budgets, and so on.
Yeah. So I'm going to force you, force your hand. What would be the best use of qualitative work in the project, you think? Where would it be most beneficiary?
Most beneficiary are the health system.
Okay.
Yeah, because in order the qualitative is best suited in order to explore in depth to the facilitators in the barrier for the implementation, so that the health system might be the most beneficiary from the qualitative aspect.
Okay, so this is management, hospital management, are you talking about?
Yeah. Yeah.
Okay. So what would you ask them? What would you be curious about?
The CEO, the clinical director, is the one who is responsible managing the clinical aspects, so that will be the one. And the other is the MC, the maternal child unit head, will give us an insight. Again, the regional health bureau, the one which is governing the facilities, will give us an insight. Plus, those maternal and child desk directorate at the ministry level, also they give us the insight.
So that's quite high up in the food chain.
Yeah.
Right? Yeah. So what I know from implementation is that you have to have every level of implementation, a stakeholder on board. Can you think of any other groups that might be useful to include there? Sure. Apart from those from the regionals, the community members are the one which is very, very helpful for the implementations of this model of care. So we engage the community members, the community health workers, and the other, like those who are working on the women's and child, so that there are so many stakeholders who have been engaged in this model of care. Yeah, so and how would you design that study? Okay. I need to draw a blueprint, since it's a new idea for the implementations, for engaging those stakeholders. For the most important thing is that sitting together and planning how we implement this together, so that knowing their role and responsibility of those stakeholders during the implementation. For example, those on the government side, they will think about the recruitment of the midwives, the organizational restructures, and something like that. Those are the community level things about advocate the role of midwives, the role of the models, and the other also their own role. So, would you prefer interviews, or would you choose another type of qualitative design? FGD might be very helpful in this case, sitting together and explore their view. So why would that have added benefit? To see the perception and the experience of different experts on the chair in order to involve in our implementation. Okay, I see some glances my way. I have to continue. Thank you.
Okay. The opposition will be continued by Dr. Van Os, Assistant Professor in Health Communication and Social Oncology at this university.
Thank you very much. Dear candidate, I completely echo the compliments that have already been expressed to you. I congratulate you and your team on the tremendous work that you've done and the impact that you've already achieved so far. Your dissertation really opened my eyes as a relative layperson when it comes to the field of maternal care in low and middle income countries. I wasn't aware of many of the things that you discussed so far, and you did that with great clarity and a fitting sense of urgency, I think. So again, compliments on your work and already the impact that you've achieved so far. But of course, I'm not here to only extend compliments. And therefore, I would like to invite you to take a closer look with me at the results of the case control study that you present in Chapter 2 on adverse outcomes of adolescent pregnancies. I'd like to start with two maybe kind of annoying, irritating questions on statistics and interpretations. After that, if we still have time, I would like to generalize a little bit. Because I had some difficulty interpreting the data that was presented in this chapter. And I've gone over them, and I think I really need your help to fully understand the findings. Particularly the findings with regard to monthly household income and the experience of gender-based violence. So if you look at table 3 on page 32, could you clarify to me how you coded the monthly income variable here? So what was the reference group? And how can we then interpret the adjusted odds ratio, as it seems that the association changes from significant negative to significant positive after adjusting for the variables in the multivariate regression analysis. And of course, this can happen. It happened before. Can happen due to strong confounding. However, I'm curious to get an idea of your interpretation on that. Any ideas, or have you looked at, for instance, correlation patterns between all the different variables that you measured that may explain this turning around of the direction of effects here?
Okay, thank you, esteemed opponent. I think I really appreciate the question you raised, but to be honest with you, I didn't see on the perspective that you asked me, but simply I measure during the analysis periods of below and above poverty levels. We collect the data by asking the women how much the monthly income they have in terms of birr, so that by referring others' papers what they consider as a cutoff point, so that we use that cutoff point to clarify below and above poverty levels. Yes, you are right that there might be a standard way of classifying these monthly incomes in terms of dollar, which is based on the World Bank, which is said to declare that this is below and above, but we use simply customizing the cutoff point from the other paper. I think that is why the concern you raised in that perspective.
So do you think there might be, in any of the other factors, there might be strong correlations that can cause the change in direction of the effects here? Do you think that for instance, the monthly income level is strongly correlated but with any of the factors that you also mentioned and include as confounders?
Yeah, the monthly income is correlated with the variable like the follow-ups of the antenatal care, since most of the women who had good income are prone for visiting facilities and something like that, or this monthly income has direct impact on the other variable like visiting the health facility. The other variable might be related to some extent in the wanted pregnancy or not, because in our contexts, from our data, we figure that those who have a good monthly incomes relatively more or less are educated, so that they have different means to control the way how they live. Yeah.
All right, thank you. Maybe I'll skip another annoying question and just go to the more general questions. I'd like to ask a question about preconception care. I think you briefly mentioned it in your introductory presentation. So preconception care, assessing risks based on lifestyle, based on medical history, based on genetics. The continuum of care that you discuss seems to mainly focus on antenatal care, intrapartum care, and postpartum care. Could you elaborate on whether you think there is a formal system in place in Ethiopia at this point that that implements preconception care, and if so, what does it look like? And in your view, is there a future for integration of preconception care in that maternal continuum of continuum care in Ethiopia? Because in the Netherlands we have quite difficulty implementing it and getting women to actually access this type of care. I'm really interested in your views.
Thank you once again for these interesting questions. To make it short, we don't have any preconception care yet implemented, and the guideline has been produced 1 year back, saying that this Currently, this guideline have been at the pilot phase in order to initiate these preconception cares. After the implementations of the preconception cares, yes, of course, there is a high chance of integrating our model with the preconception care that is highly recommended by WHO.
And how do you think you can get the women to actually access it, to make really use of these?
This preconception care?
Yeah.
Yeah, maybe we use different platform. For example, for antenatal care, the women can by themselves. For the preconception care, it's very difficult for a country like us, which is very insufficient. But we may integrate the preconception care with the OPDs, the immunizations, and other services, so that we inform the provider whenever they encounter the woman, just to send them to the preconception care to give them an information, education, like that. Then by integrating in this fashion, we can initiate this preconception care.
Challenging, but
of course.
Yes.
Yeah.
All right, if there's still time, I'm not sure. Then I would like to ask one of the Paranymph to read out Proposition 8, please.
The lack of adequately trained professionals undermines all efforts to improve maternal and neonatal health outcomes effectively.
Thank you. So it seems that if I understand this correctly, any initiatives to adapt and to improve the current system that is in place to be more in line with the midwifery-led continuum of care, they would have to start here with getting enough, sufficient, adequately trained professionals. How, if that's the starting point, how would you go about do that? Do you have any ideas on how to reach this?
Yeah, thank you once again. I think that is the very critical issue we are facing, because there is a clear shortage of human power, especially in the perspectives of midwives. In the country, there is only 25,000.
Hora est.
We finish your answer.
Okay, only 25,000 midwives are available for 126 population. That is very undermined. But the issue will be tough for implementing midwifery-led cares, not on the sides of the urban, in the sides of the rural. There is minimal midwives are there. In the urban, there is sufficient midwives, since it is in the countryside. The very difficult situation is in the rural side, there is few minimal midwives. They are poor in terms of the skills. It is very difficult to access them, and also the infrastructure is very poor. So in order to combat this issue, as I said before, for implementation, it's very important to work with different stakeholders. That is the answer. Yeah, I finished. Thank you. Thank you. I finished that, yeah.
Thank you very much.
Rekiku Fikre Abebe, the time appointed for defending your thesis has passed. The degree committee will now discuss the quality of your thesis and your defense. And I request that you and your company leave this room, and after the deliberation, the video will come and collect you to return to this room.
Please all rise. I invite you and the Paranymph. Please. Please be seated.
Rekiku Fikre Abebe, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Dr. Goebbels is authorized to confirm upon you with this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise.
So, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Rekiku Fikre Abebe, the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Please move a little bit forward so we can take a good picture.
Okay, dear Dr. Abebe, dear Rekiku, today I have the honor to be the first to congratulate you on the important milestone that you have reached in your career. Of course, also on behalf of Sanne and Dr. Wundbosen, who is present online. We want to congratulate you, not only you, but also your colleagues, friends and family, especially your wife and children, who have supported you throughout this journey. But I would also like to congratulate Ethiopia, because with you, it has a fierce advocate for maternal health care and women's rights. You have really created an impact in practice with your project. So you approached this back in 2022, as you had seen papers of one of our other PhD students, who was focusing on maternal care in Uganda. You were eminent that you wanted to pursue a PhD as well. And you had ambitious plans and were certain that you were going to finish within 2.5 years. And despite your impressive CV, already having a long list of publications, we tried to temper your expectations a bit, because PhDs usually take 4 years, and for our external PhDs, it's often longer because they have to do it in addition to their job and other priorities. But nonetheless, you were certain you would finish in time, despite your plans, despite your very busy job, and despite having a family as well. So we thought, well, we will see. But you showed us and proved us wrong. Your pace was always very fast, one straight line towards your goal. So throughout your project, I also learned a lot from maternal care in Ethiopia and Ethiopia in general. I also learned, however, that Ethiopia has a very interesting and unique date and time system. 7 years behind on our calendar here in the Netherlands, and with 13 instead of 12 months, with New Year's being in September. Also, the time system is different, starting to count from sunrise to sundown instead of our 24-hour clock. Well, you might wonder how I learned all of this. Well, let's just say that we had quite some meetings where either Sanne and I were wondering where Rekiku was, or the other way around, that you were online and we didn't know where we were. And when we then got our schedules right, there was always the half-year annoyance that we changed to wintertime or summertime and had a mismatch again. Even when you arrived this week for the defense, we had a mismatch again. But in the end, we found each other and we managed to get the schedules right. So in December of last year, you also visited Maastricht, and it was very nice to meet you in person, discuss the project face-to-face, and have you join our department Christmas celebration. Together, we also visited the hospital here in Maastricht, including the delivery ward. And coincidentally, the delivery room that they showed us, that they showed you, was the room where I also had delivered my son years earlier. And it brought back a lot of memories. But standing in that room, hearing the nurse explaining and showing all the equipment and instruments, it hit me how enormous the contrast is with the Ethiopian situation. And a sadness overwhelmed me. And then I looked at you, and you were not sad, you were inspired. You were taking pictures, asking questions, wanting to know everything about it. So you really are extremely motivated to make a difference. Day in, day out, you are out there implementing interventions, teaching new generations of midwives, lobbying for better policies. You have showed us what it really means to make a difference. So thank you, Rekiku, for being an inspiration to us. Today is your big day. We are very proud of you and know that your family, friends and colleagues online are also very proud, and they are with you in your heart. So no matter where you are, you have their support. So congratulations, Dr. Rekiku. Enjoy this moment. You have earned it.
Dear Dr. Abebe, it's also my pleasure to congratulate you on behalf of the Board of Deans of this university with this new degree of doctor. I will also congratulate you with the impact of your research for the society of Ethiopia. It's impressive, I believe, and you really made an important difference for health, for the mothers, but also for the newborns. Congratulations with that, and we hope that you continue this in the future, and all success with further implementation your program in Ethiopia. Hereby I will close this academic ceremony. Before congratulating the new doctor, we will take a picture in front of the screen so that the co-supervisor is also on the picture, and unfortunately Dr. Tengele, we are still missing his picture, but yeah, we will making here the first photo and then on the stairs in the central hall. Hereby I close this academic ceremony.
Please arise and please come forward.